some days higher than 2,000. So we hope that the situation will be better. We hope, but we have more positive, but no asymptomatic patients. We have more asymptomatic patients than symptomatic.
Is it easy to test and screen, or it's complicated?
Oh, I think it's easy because actually currently they give the authorization to many labs, the private laboratory to practice the test. So it's more easy to have it. Yeah. Fed, it's time on I think it's...
Yes, it's time. I think it's time.
We can start?
Yes, please go on.
Okay. So, dear friend, dear colleague, we are pleased by the distinguished honor we have been given by the Moroccan Society of Neurosurgery to organize this second series of the Morocco webinars during the 2020. The effort of all colleagues worldwide are the proof that science is the heart of the practice. Despite the COVID-19 pandemic, education in neurosurgery is taking a new shape today. We programmed different webinars, different topics discussed by eminent masters worldwide. Our goal is to offer to every participant the opportunity to discuss actively with our speakers and panelists, and we invite all to join us every week to discuss a new topic. Today, we are delighted to discuss skull-based surgery with the participation of three eminent experts. First, it's it's by pure chance or coincidence today that our three speakers are native Arabic. I believe me, it was certainly unintentional. Maybe I was consciously influenced by my position as president of Pan-Arab Society, Neurosurgical Society. But we will probably have the pleasure of enjoying a verse of Arabic poetry by my excellent friend, Jack.
Now you told me, I would have prepared something.
This is why I tell you that. So let me welcome Professor Jacques Marcos of the University of Miami, Professor Ahmed Kanaan from the University Al Faisal of Riyadh, and last but not the least, our mentor, Professor Abdeslam Khamlichi from the Morocco Mohammed V University of Rabat. Thank you very much for all accepting our invitation. I welcome also the panelists, the president of the of Moroccan Society, Professor Abdel Hakim Lakhdar, the president of Moroccan Society of Spine and Spine Cord Surgery, Professor Saeed Hilmani, and I hope that Professor Ouammou will join us in a few minutes.
He's here.
He's here. Hi, Sir Abdullah. He's the president of the Moroccan Association of Private Practice Surgeons. Hi, Professor Abdullah. Welcome. Hi. As you know, education is a tradition in neurosurgery in Morocco. Since its creation in 2002, the WFNS Rabat Reference Center for training young African neurosurgeons has always been committed to education and training for African neurosurgeons through ensuring, of course, basic training 5 years, as well as organizing yearly courses and workshops. This training program was sustained thanks to, of course, the combined efforts and dedication of the WFNS Rabat Reference Center team, composed by all the Moroccan university, and African neurosurgery, and many outstanding lecturers from all over the world who accepted to participate in these different courses. Jack, you has been, of course, you were with us for, I think, at least one of these courses. So I take the opportunity today to make this announcement because of the current COVID situation 19, you know, we decide this year to organize this 12th edition of the WFNS Reference Center course for African neurosurgeon in virtual mode. On November 18 and 19, 2018, you saw in the slide the photo. And neurosurgeon, bien sûr, in the virtual mode. And the topic of this 12 course is the new challenges in neurosurgery. Be connected and keep updated. So without delay, I give the floor to our panelists. First, may I ask Professor Lahdar to introduce our first speaker, Professor Jacques Morcos. Thank you so much.
Thank you, Professor El Abadi, for all the efforts you are making for organizing this all this scientific activity and your involvement in in the organization of these activities in the Moroccan Society of Neurosurgery. I thank also all the guests, Professor Jacques Morcos, Professor Imad Kanhan, and our mentor, Professor Al-Khamlishi, for accepting the invitation. I will give a brief and short, very short presentation of Professor Jacques Morcos, because it's difficult to present all the CV of Professor Morcos. I will thank him first for accepting the invitation. Dr. Jacques Morcos is a specialized in the field of cerebrovascular surgery and skull-based surgery and neuro-oncology. Currently, he is the director of cranial surgery in the Jackson Memorial Hospital and the director of cerebrovascular section fellowship program, University at Miami School of Medicine. He is specialized in the field of cerebrovascular and skull-based surgery, and he completed his neurosurgical residency at the University of Minnesota. He then completed 2 fellowships, one in cerebrovascular surgery at the University of Florida, and the second in cerebrovascular and skull-based surgery at Barrow Neurological Institute. And in 1995, he joined the faculty at the University of Miami Department of Neurological Surgery. He is involved in all aspects of vascular surgery, bypass, arteriovenous malformation, aneurysms, and also in all aspects of skull-based surgery, including pituitary surgery and all aspects of skull-based surgery, as well as glioma and aspects of neuro-oncology. He has also an active activity in radiosurgery practice. He received numerous awards, such as the Dalziel Ferns Prize from the Royal College of Surgeons of Edinburgh for the highest marks during 6 years, at the Peyton Society Award for ranking first in the American Board of Neurological Surgery written exam. He is director at large in the North American Skull-Based Society, serves on multiple surgeons and the World Federation of Neurological Societies committees, and he is the past chair of the Joint American Association of Neurological Surgeons and Congress of Neurological Surgeons cerebrovascular section. He is on the edition board of several journals, including Journal of Neurosurgery and World Neurosurgery, and his research includes directing a microsurgical anatomical dissection lab in the anatomy of the brain and skull-based and surgical approaches, and he is also involved in projects using virtual reality to study the brain, blood vessels, and skull base. So we will give a talk about the orbital surgery and anatomy, as a part of neurosurgical practice. Thank you, Professor Jacques Marcos, for all your contributions, and please, it's to you to give the conference. Thank you.
Thank you. I thank you very much for this very generous introduction, and I cannot tell you how much it's a pleasure for me to share the stage with two of my very favorite people here, Imad Kanan and Professor Al-Kamlishi, and of course, I thank Najia for inviting me to share this hour with my Moroccan colleagues, friends, and whoever else is listening today. So I thought I would talk about the orbit and orbital tumors because it's perhaps perceived as not being part of neurosurgery, and I want to make sure our young people realize that it is part of neurosurgery. Again, thank you for the invitation. And before I get going with the topic, I also hold a weekly webinar on Thursdays, for example, on skull base and vascular. And on the bottom right, if anyone is interested, this is the link to register. Next week, for example, we have two speakers on pituitary tumors, Nelson Oyesico and Eduardo Vellutini. And we have this every week. I am dying to go back to Morocco. I have not seen those places. The Grand Atlas, I have not been. It looks fantastic. Les Cascades d'Ouzoud. I have not been to Fez to see Les Tanneries de Fez or other places in the Atlas Mountains. And when COVID is gone, you can count on me to come and visit your beautiful country. And one more thing, I would like to say that, you know, I'm from Lebanon originally. We love proverbs. And there are these two proverbs that are said to be very popular in Morocco. I don't know if you'll agree with me, but I love them if that is true. Le cœur de l'idiot est dans sa bouche, la bouche du sage est dans son cœur. I certainly hope I won't make a fool of myself speaking today and that I apply to this. And I love the next one, which keeps us on the ground and not allow our egos to fly too high, parce que même les plus hautes montagnes commencent au sol. And so, you know, a little wisdom for us all to remember. Skull-based surgery is a team work. This is our weekly Tuesday skull-based conference. When it was much smaller, I've organized it 10 years ago. Every Tuesday we meet all the disciplines to discuss, and I called it MOBS, multidisciplinaries of the base of the skull. If you're engaged in skull-based surgery, you need to be part of a team. It's not a one woman or a one-man show. The outline of my talk is a little bit of anatomy, surgical approaches to the orbit and periorbital area, and some case examples. Carolina Martens was a Al Roten Fellow and has written a beautiful paper and several others on the microsurgical anatomy of the orbit, and she calls it the rule of 7. So let me show you where the rules of 7, everything seems to line up in groups of 7 in the orbit. So you can see the 7 bones forming the orbit here: zygoma, maxillary, lacrimal, ethmoid, palatine, sphenoid, and frontal bone. As Al Roten used to say, you deconstruct the skull to understand it and put it back together. To understand the orbit, you need to understand the ethmoid bone, the frontal bone, the maxillary bone from below, the frontal and ethmoidal orbital plates. You need to understand how they come together, particularly the complex shape of the lacrimal bone, the inferior border, the anterior border, posterior, and superior. You need to know how the lacrimal bone fits very nicely here. And then when you continue to build the sphenoid bone around this, you get a better complete understanding of the osteology, how the greater wing of the sphenoid forms the lateral wall along with the zygoma, and you can see it down here as well. How the orbital process of the palatine bone fits right here on this surface. And that's a palatine bone. And I mention all these things. Obviously, I don't have time to go in great detail to encourage people who are interested in orbital anatomy to really study the osteology in the lab very closely before you start thinking of soft tissues. When you've done the osteology, then it's time to study more the detailed anatomy. And it's, believe me, it's so much easier than complex brain anatomy. The orbit should not be a mysterious zone for neurosurgeons. The rule of 7 continues. There are 7 intraorbital muscles, but only, of course, these are through the attached to the annulus of Zinn. And the structures that are outside the annulus of Zinn are lacrimal branch, frontal branch, and trochlear branch. Everything else goes through the annulus of Zinn. And that's another view of the annulus of Zinn. The ophthalmic artery, it's important to understand its course as it starts medial, then inferior, then lateral to the optic nerve, because you may have to deal with that when you are dealing with intraorbital surgery. Of course, it's very important to realize the retinal artery leaving the ophthalmic artery, and then to understand that there are lateral and medial branches to the ophthalmic artery. Here are the lateral branches. One of them could be the recurrent meningeal artery. Another one is the lacrimal branch. And the medial branch, you can see them here, anterior and posterior ethmoidal artery, which is very important for endonasal endoscopic or anterior open skull base approaches. I also remind you where the superior ophthalmic vein is situated, as I will show you case examples later of why we need to understand the SOV. I'm not going to go into the details of all this, but of course, I encourage those of you who are not familiar with it to study it. It's important to relate the orbit to the skull itself. So one way to think of this, when you look from above, the bulbar area fits with the frontal area, the retrobulbar area fits with the cribriform, and the apex of the orbit is level with the planum. And these are some numbers in millimeters to give you a guide of where various things are. So many pathologies occur in the orbit. I am certainly not going to read this whole list, but you can quickly peruse all these pathological conditions that can occur in the orbit. This is an important slide, similar to what we say when we talk about spinal cord tumors. We say extradural, extradural or intradural extramedullary or intradural intramedullary. You have to think of the orbit in a similar way. Extraconal pathology or intraconal. And then each one of them has subdivisions, intradural, extradural, or is it lateral, central, or medial? That's where you start with building up your differential diagnosis, is what compartment within the orbital cavity is the lesion. What surgical approaches could you entertain? Again, by the way, all of these dissections, I'm sure you recognize them, they're Roten dissections. You can enter from above, which is the most familiar to neurosurgeons. You can go either medial to the superior muscular complex, levator palpebrae and superior rectus, between superior oblique and that. Here is superior oblique, here is the levator complex. That's a medial route from above. Or you can go centrally, from above, separating superior rectus from levator palpebrae, such as what you could do for this lesion, or lateral route. So from above, you can go medial, central, or lateral. This is an important slide to put most approaches together, or at least the concept of them, and how we all in skull-based surgery should interact with each other. You can think of the orbit as sectors of a clock. So you think generally of a neurosurgeon coming from above, an oculoplastic going from anteriorly or laterally, the head and neck surgeon coming from below, the rhinologist from medially. But of course, it doesn't have to be this way. That's the area of comfort of each one of those specialists. We all need to each of us, if we're going to do orbital tumors and orbital surgery, need to completely understand the other specialists' zones as well. That's how we progress. For example, many neurosurgeons perhaps don't know these approaches, but they're useful to know. The orbital approaches, again, I'm not going to read them, but they're important to understand, to know what exposure they give you. We don't need to be specialists at making these incisions, but if we're going to work with an oculoplastic surgeons, we need to understand the difference between a subciliary skin muscle flap incision, stepped or non-stepped, or simply a subciliary skin flap. There are several layers to understand. The various eyebrow, modified lynch, or even conjunctival incision, the lid crease, the subciliary or the lateral approach. This is a whole list of approaches, the benefits and limitations of each. I don't have time in 20 minutes to go over all this. This is perhaps what a typical neurosurgeon would be more familiar with: terrainal, supraorbital, or fronto-orbitozygomatic approaches to the orbit. So let me take you very quickly through probably what you are most familiar with, and the variation on the COZ, or cranio-orbital approach. All of us perhaps know how to do this. You can tailor it to be cranio-orbital without the zygoma. You need to understand, again, the osteology of what that is. You need to understand where the anterior clinoid is and the optic strut at the base. That's a typical approach, COZ or CO. You may or may not associate it with the Dolling cavernous sinus dissection. I'll again show some case examples later, to expose the anterior clinoid and to cut towards the superior orbital fissure. Many years ago, I wrote a paper, a very small modification of the Dolling technique, and that's how I like to teach my residents. Dolling, of course, described cutting this fold before developing the lateral wall of the cavernous sinus. I prefer to do the opposite. I like to separate the lateral wall of the cavernous sinus, leaving the fold intact. Then I can see the anterior clinoid. Then I can cut the frontotemporal dural fold. I'll show you, this is one of our cadaveric dissections. So if you reverse the steps, it's easier to understand, at least for the beginning surgeon, a neurosurgeon. And then, because that's anatomy that you are interested in exposing. And then you can do your anterior clinoidectomy if that's what you need to do. And that's an exposure of that. And that's a third nerve and fourth nerve, and exposes, you can see the anterior loop of the carotid artery, and you can see the optic strut where it was. So let's go through some case examples. Orbitocavernous schwannoma. You can see this a poor patient with a very bad proptosis and limitation of orbital movements. And I'm going to show you one of the principles of removing an orbital schwannoma that extends into the cavernous sinus. I will skip some details, but you can see the MRI, the typical schwannoma in the orbit going back to cavernous sinus. So the approach I would select is a modified cranio-orbital. We've done already the approach. Now this is an extradural. I like to do extradural anterior clinoidectomy on tumor work, and I like to do intradural clinoidectomy for aneurysms. So here we're drilling the anterior clinoid. We've decompressed the optic canal. So next we enter the orbit. We enter the orbit through a lateral periorbital incision. As you expect, the tumor herniates because it's under pressure. So then we remove the schwannoma from the orbit first to decompress it. Typical schwannoma. Now, when you've done the orbital part, now it's important to go to the cavernous sinus portion. And that's, here we are doing a Dolling technique. And what's important, unless you understand how the orbit becomes cavernous sinus, you will not know how to communicate the two compartments. Very important to use tissue sealant to stop venous bleeding, like Dolling has taught us many years ago. And the next step is to open the periorbita, and I'm sorry, the lateral wall of the cavernous sinus, with intraoperative monitoring of stimulation of the nerves. There is V1, and there is a tumor bulging. And now you can mobilize the tumor from the anterior cavernous sinus, and you have to mobilize it until it connects with the orbit. When you are finished removing this, here is the last piece coming out. It's important to put an instrument through the superior orbital fissure right here to make sure you haven't missed any tumor in between the orbit and the cavernous sinus. And I think this is why we neurosurgeons need to understand so well the anatomy of the orbit. Do you see? I'm putting my instrument from the cavernous sinus to emerge into the orbital surgical space. So that's what you should do really when you have combined tumors that are in the cavernous sinus and in the orbit. Another example would be a simpler example. This is narrated, but I'm going to skip through it. Look at this man with proptosis and ophthalmoparesis with the third nerve. This is a classic dermoid cyst of the cavernous sinus eroding into the orbit. This only requires a Dolling technique. And the way I do this is this way. The way Dolling taught us, peeling the lateral wall. And I just want to show you the typical appearance of a dermoid cyst. Look how it is, and it even has hair in it. It's an entirely extradural operation. No need to see CSF. And then after
has been completed, there is no further.
You can see the periorbita.
Abnormal.
And here he is post-op, well, 1 day post-op, unchanged with his ophthalmoparesis. Many approaches, there's been a move towards doing pure transorbital endoscopic approaches. I have not been a big fan, but they are certainly doable. You have to be careful you don't limit your exposure. I'm going to give you an example of a publication where this actually shows that it is a limited approach. This is my good friend Ted Schwartz. He did the transorbital endoscopic approach to this sphenoid wing meningioma that is entirely intraosseous. Well, I mean, he did it without the intent of removing everything, but it did achieve a partial removal. But you see the post-op scan shows, of course, it's not a complete removal. So if your goal is a partial debulking of an intraorbital lesion, this is an endoscopic view, then certainly that's a nice approach, but it cannot be a good approach for a radical resection. Here is, in that publication, the post-op imaging. And that's a pre-op in that publication at the top and post-op at the bottom. Some more case examples of mine: gradual decline in visual acuity of the left eye. Look at the lesion right here, medial orbit. In the old days, I would have done a cranio-orbital approach, but since we know how to use endonasal endoscopy, this is a perfect approach for endonasal transorbital because it's medial to the optic nerve. I'm sorry, I think somebody maybe has their microphone on. There is some feedback, I'm not sure. So that's what I chose. And I will show you a typical video of a cavernous angioma of the medial orbit. This is the right side. This is endonasal endoscopic, where, of course, all of us who do pituitary tumor are very familiar with this. All you have to do is enter the orbit laterally. Here we are drilling lamina papyracea. And then you open the periorbita. Here is orbital fat is a three-hand technique. The rhinologist is assisting with holding the endoscope. You may have to bipolar the orbital fat. And here is inferior rectus. So I'm working above inferior rectus, looking for the lesion. Of course, navigation helps. And with the cavernous angioma, all you have to do is find it. Once you find it, don't cut it into pieces. simply grab it and kind of tease it out. It's going to come out any second. There is a small vessel on it. We're doing bipolar. And here is the lesion. You can just see it right now over here. And all I need to do is a pituitary microrongeur, grab it, and with the other hand, kind of tease it out. Very simple, clearly the best approach. There is no need for a craniotomy to do this. These patients go home that same day, that afternoon. You're not worried about CSF. This is, we put alloderm on top of the periorbita. There's no worry about CSF leak. It's really a sinus surgery. So this is where I think we've made some wonderful advances with endonasal endoscopy. Here is post-op, the lesion is removed. Same thing you can do for schwannomas. I'll show you a quick video of an orbital apex schwannoma, not a cavernoma. Again, medial to the orbit, medial to the optic nerve. As long as it is medial, that's the best approach. Endonasal, on this time it's on the left side. Again, opening the periorbita, and I'll show you. Here is inferior rectus. Look at the schwannoma right there. It takes probably 3 minutes to, once you're on it, to actually pull it out. The approach, of course, takes long time, but once you're on it, it's very simple. You grab it, and it's a schwannoma. It's a nice pathology, and it comes out one piece. And if it doesn't, you go and chase the other piece. Again, patient goes home the same day when you do these this way. A very, very big advantage. I'll show you another example of where the neurosurgeon may need to be of use. I'm sorry, I only have 20 minutes, so I'm going to skip hard. Carotid cavernous fistulae with superior ophthalmic vein approach. When we've reported my series of 10 cases many years ago of doing a cut down on the superior ophthalmic vein when your endovascular colleague cannot access the CC fistula endoluminally. Sometimes you cannot, there is no access. And often this is the only access you have to get into the CC fistula. So, and most oculoplastic surgeons really are not familiar with this because it requires certain understanding of cerebrovascular anatomy. So I encourage you to know how to do this. I'll just show you very quickly a video how to do this. It is simply a glorified cut down. I'll go quickly. In the operating room, you do a skin crease incision above the tarsal plate. This is where on the right side, the video is sped up a little bit. And all you have to do, I like to do it under a microscope, look for the orbital fat supratarsal, and then look for the arterialized vein. You may use navigation, you may use a Doppler, whatever you need to find it. Of course, don't injure it. Here is a vein. Once you find it, you put a traction suture on each side of it, and then you do a small venotomy. And I like to use this system, the Cook 4 French system, to simply cannulate this. Once you cannulate it, you do a quick venogram in the operating room, you close the incision, and you take the patient asleep to the angio suite where your colleague can access this and, of course, cure the fistula. You can see here the venogram and the CC fistula has been cured. Very handy, very handy. I want to warn you that not every lump in the orbit is a tumor that needs to come out. I'll show you this lump in the orbit that a plastic surgeon saw first and went in. Lucky him, he did not puncture this thing, but this was a huge vein of an AVM. I will show you in a second. He closed, of course. Interesting case. Look at this parietal AVM that is draining through the sylvian vein. Look at this unusual drainage. Look at that superior ophthalmic vein on your left, heavily arterialized. Luckily, again, the plastic surgeon did not puncture it. So yeah, we're not going to show you the case. It's an AVM resection. And of course, the vein disappeared. Not all lesions intrinsic to the optic nerve are inoperable. I want to show you this, I think, an important thing. Many people think that cavernous angiomas of the optic nerve or the chiasm are inoperable. That is not true. We're actually publishing a paper of 5 cases, but I want to show you one example. This is not intraorbital, but it is in the chiasm. I'm going to skip through some of the text. This patient, just to say, presented with 20/300 vision in the right eye. Remember that number, 20/300. She had an MRI that showed this lesion that honestly I thought myself was an optic chiasmal glioma. I did not think of cavernoma. I went in at surgery. I did the craniotomy and a quick video of that. I want to show, here is the appearance. Here I recognized it the day before because there is a blood hematocrit level. I said, oh, this could be a cavernoma. So what you do, look at it. Look at the appearance. This is the optic nerve. It's sped up. You have to remove these very carefully, of course, but you have to remove them or the patients will go blind. And I will show you what it looks like at the end. I thought for sure this patient is waking up blind in this eye because at the end, it looked like the huge hole in the optic nerve. You can see the optic nerve and I'm thinking, gee, is there any vision left here? What I want to show you is that this patient got better, not worse. Here is the pathology of the cavernoma, 20/30. She was 20/300, she became 20/30. And everybody who's done these cases can tell you this. Patients get better by removing cavernomas intrinsic in the optic nerve or optic chiasm. Here is our colleagues in ophthalmology doing follow-up optic nerve photos of this patient and OCT. I think I'm running out of time, so if you don't mind, I will go to my to one summary message I would like to give you. The lessons that I learned about orbital surgery over time. Inadequate tumor resections around the sphenoid bone, very common with meningiomas. I often get patients with residual tumors in the orbit from removal of a sphenoid wing meningioma. Neurosurgeons was not aggressive enough. They resect the intradural portion, but ignore the bony involvement. One message, please drill the anterior clinoid for all clinoidal and tuberculum sella meningiomas. Sam Al-Mafti was absolutely correct. Many times you will find meningioma in the optic canal that you did not suspect. It's a matter of safety, exposure, and uncovering of hidden pathology. And I usually do it extradurally, not intradurally. And lastly, the message is really the message of this talk is work with partners of other specialties. Remember, the orbit has 360 degrees around it. Don't think of the orbit only from a neurosurgeon's from above type of approach. And that's a message I'd like to give you, and I will stop sharing my slides. Thank you very much.
Okay, thank you very much, Jack, for this amazing, fantastic talk. And really, we appreciate very much this field because it's rarely the neurosurgeon, as you said judiciously, rarely the neurosurgeon, deal with this tumor. We need to be, as you said, in multidisciplinary, of course, team. So I think we will leave to all the question at the end of the tree talk. And I ask Professor Helmani to introduce our second speaker, Professor Ahmed Kanan. Please, Professor Helmani, you are here?
Yes, I'm here, please. Thank you, Professor Abadi, for this kind invitation, and I would like to congratulate you for all the efforts which we do for improving neurosurgery in our country, and give us opportunity to meet some honorable speakers. It's honorable for me to introduce our friend and our guest, our best guest, Professor Imad Kanaan from Arabic Saudi. I will try to give a short summary for his long view data for this eminent neurosurgeon. He's Professor Imad Kanaan. He's professor of neurosurgery at Al Faisal University from Riyadh. He's director of advanced neuroscience clerkship at the same university. He's director and chairman of the Department of Neuroscience Training and mini education committee at the same university. He is the past president of our school-based surgery society. He's the chairman of the WFNS Neuroanatomy Committee since for this year, 2020. He's a member of many international societies and committee of anatomy and school-based surgery. Also, Professor Imad Kanaan, he participated to many school workshops, and he was a director and faculty of several international workshops in school-based anatomy and endoscopy and other topics. About his publication, he had published more than 100 scientific publications in per journal, and participate to many book chapters. He contributes also in some international education webinar, including 5 webinars for WFNS. Professor Imad Kanaan, he is a member of editor board of many international journals as Surgical Neurosurgery and Neurology International, ACTA Neurosurgical Journal, Asian Congress, and others. Thank you, Professor Imad Kanaan, for participating at our webinar, and he will talk about simple approach for school-based meningioma. Please, Professor Kanaan.
Well, I will. There is some noise coming, but anyhow, thanks for the introduction, Professor Said Hilmani. My family members from Morocco, Dr. Kamlishi, Dr. Lakhdar, all of them, they are close friends, and I'm very happy to join your webinar. I cherish Morocco because my dad was living in Morocco for at least 10 years as a dentist in different places, and I was a frequent visitor when I was still in the medical school. So I have a special good memory from Morocco, and I remember the 2005, the very successful World Federation meeting conducted by Professor Abdel Salam, where he inaugurated that training center to train young generation of neurosurgeons in Africa. And this is a job well done. Thanks for the introduction. My topics will be a little bit contradictory to what Dr. Jack said, and I'm going to give some points that I feel I want to share after 35 years of experience in the field. Do you see my slide?
Yes.
Yes.
All right.
Very well.
So we cannot start this presentation without talking about history. We have an evolution of neurosurgery for almost more than a century, since Cushing and Dandy. And then we have a half century of microsurgery, thanks to Professor Yazajid, who taught us microsurgery. And then there were a lot of contributors that they taught us about all these skull-based approaches in the past 3 or 4 decades, being Dr. Hakuba with the pre-sigmoid approach, Professor Dollins and Mufti, but none of them can claim that this is his approach. if you realize the evolution, each approach came from a predecessor. If you talk about fronto-orbitozygomatic, you have to give credit to Dr. MacArthur and Frazier, who first introduced that approach to take the orbital rim and even take the zygoma. And Professor John Jane, he fine-tuned it, and of course others added their tailored approach to modify it according to the technology and development available at that time. So I call approaches, they are either authoritative, you will learn it from your seniors and you became acquainted with, and this is your baby, and you keep feeding that approach, or you should be an innovative approach that you will tailor it and you adjust it according to what is available, modern technology, you embrace this technology and add it to this one. Why isn't it?
Imad, click on the slide first, then it advances.
Okay. All right, so these people, they taught us how they adjust their approach. So the decision-making of the selection of approach is very paramount important, whether it's the tumor location, the size, direction of growth, the pathology you are dealing with. Most of all, importance is the patient age, presentation, and comorbidity. You cannot take somebody with a 90 and make a complex approach where the approach will kill him rather than his disease. And the selection would be tailored to have a safe and short to the target, patient-specific, disease-specific, and you should be able to manage your complication if they occur and have given you the optimal potential to reconstruct and repair if you cause a defect. So we moved from the conventional surgery with gross exposure. If you take one of the previous neurosurgical books that when I was first year in neurosurgery, I remember Dr. Kempe book that was all gross anatomy. Meningioma, never microscope for meningioma. It's a shame you put the microscope on the meningioma. You leave it to the end if you need. And then we move to the functional exposure and more advanced microsurgery. But slowly, I start reverting back to the simple approaches. And I tailored my approach accordingly. It doesn't mean for the young generation, they should not learn these complex approaches. And the other additional we have now, the endoscopy, I was an opponent to start with, but we have a good example from Dr. Jack Morco's presentation, how you can adapt technology to fit in your intervention and make your approach a more better outcome. So we were helped by the technology, of course, and the modern images that has a major input on our practice. So I put the two arrows, but in reverse direction. We start with the retromastoid, retrosigmoid, and then ended with the complex pre-sigmoid approach. Now slowly, I'm not doing that much of pre-sigmoid approach. This approach, it takes sometimes 7 to 8 hours to achieve what you want. The exposure will give you to the petroclival region is a fantastic, but by the time you have to go after the real lesion, you will be knocked out. And it's a 3 approaches in one. You do a simple mastoidectomy, you do a retrosigmoid, pre-sigmoid, and you might complement it, like in Hakuba's case, a fronto-orbitozygomatic. So this is a fantastic approach, but it has its own indication, and sometimes you have to do it. But you can overcome this with another technology, like, as I said, the suprameatal approach, retrosigmoid, and complement it with some endoscopic exposure and incision of the tentorium from below. So that's why I said I revert back to these powerhouse approaches. And the same with the pterional subfrontal. We moved to the fronto-orbitozygomatic. There were several modifications. Then we did the trans-eyebrow minimal fronto-orbitozygomatic, and we published more than 16 years ago. And the frontobasal transbasal approach, it still has its indication, but we get the standard from it. and I keep it for a specific, really specific indication. The same with bifrontal. People did pediatric neurosurgery. This was the most common approach for craniopharyngioma. Nowadays, this approach, I don't like it. And I will tell you in one of the slides what is my reservation about it, but it has some indication and people have some good result in their hands. So, but the most two important things, whatever the exposure, how big it is, if you see half of the brain, you are not going to be a good surgeon and you are going to achieve a good outcome without a microsurgical technique. This is the essential part to make a procedure successful. And this is what we have learned by Professor Yazarjil and Majid Sami for the posterior fossa for the acoustic. And the early use of microscope is very important step that I learned from the Professor Yazarjil. He started opening even the dura, not because he doesn't see the dura, but he get his eye acquainted with the microscope. Because most of the people, they say, especially when I've seen people in the old days looking for an aneurysm, said, no microscope, except when you reach the aneurysm, we want to put the clip, you put the microscope. This was more than 20 or 30 years ago. The same with the meningioma. Meningioma is a gross resection, and when to the end, if you have difficulty, you might put the microscope. Most people did that. They got short temper. By the time they put the microscope, they didn't tolerate having the microscope in front of their eyes. So this is very important to get acquainted, use the microscope from the beginning. And of course, there are different categories that make me, several years ago, about 7 years ago, I published what I call the 5D concepts in the section of a meningioma, and I'll go after this shortly. That classification of the grading of the meningioma or classification of meningioma done by Al-Mufti and Pamir, I found it one of the very good one for the suprasellar meningioma and anterior clinoid meningioma. It depends where the attachment is and give you where the difficulty, where if you don't have an arachnoid plane, then you might have difficulty, you will be aware, and you have to be careful with drilling the anterior clinoid as mentioned. This is the approach we like. The zygoma prominence will be the highest and we make use of the gravity. But again, this is the first D from the 5D concept. It's the drilling of the lateral sphenoid wing all the way down. I used to drill the anterior clinoid in every case. Nowadays, I don't drill the anterior clinoid in every case. I don't need it in every case. In cavernous sinus surgery, yes. In orbital surgery, yes. In some complex meningioma, yes. But I will show you many cases that I have done the roofing of the optic foramina without drilling the anterior clinoid, because the optic foramina roof is more medially. And I agree with the point, if you want to take the clinoid for vascular, I don't like to do it extradural because you might cause a rupture of the aneurysm that is just behind that clinoid. But the giant meningioma on the anterior clinoid, sometimes to do it extradurally will be even difficult because you keep hitting the optic nerve by this mass form and you don't see how much you are pressing when you are doing the anterior clinoid drilling. But the advantage of drilling the sphenoid wing, it gives you a near access to any lesion in that location, being from the olfactory all the way to the suprasellar area, within 1 centimeter as by the measurement made by Professor Lang. You are very nearby, and this is the way you can control your equipment. Once you are there, this is the advantage of the pterional approach. You will see the vital structure, the neurovascular structure early in your procedure. Not like a subfrontal, the frontobasal or the bifrontal approach. You are on the dome or on the front part, and the most vital structure would be at the end of your procedure. Here you have a control, you see them ahead of time. Then you start devascularization from the base. You convert a vascular tumor into a vascular tumor. You start doing segmental resection from the base up like a fan and the central debulking, and then you flip that tumor from the brain rather than the brain from the tumor. So if you apply the rules of microsurgery and take the concept of releasing CSF from the basal system early enough, you are very good with the exposure, even without retraction in many of the cases. And the final two I mentioned, the roofing of the orbit, the optic nerve is very essential. It's not only to decompress the optic nerve, but it makes the manipulation of the nerve much easier rather than to have the nerve tethered at the falciform ligament or at the foramina, optic foramina. It will be ischemic after a few manipulations. And the other things, you will expose the nerve early if it's hidden inside that meningioma. Arachnoid is your friend. I always call it the natural patty, and don't lose it because it protects you for the neurovascular structure. These are the 5 Ds that I mentioned in my practice. What is the advantage of opening the sylvian fissure? In some of supracellular meningioma, I release the CSF from the system, then I open the proximal part, so it's untethered the frontal lobe, and it makes a avulsion of the olfactory nerve at the bulb unseen, and the depth or mobilization of the frontal lobe much easier. It relieves the tension. It relieves, you can have exposure of the vessels and the sylvian fissure if the tumor going along or around the internal carotid artery. It releases CSF and minimal injury to the frontal lobe and better exposure of tumor. Advantage of optic nerve deroofing, I agree with you on most of tuberculum celli meningioma specifically. They have tumor tongues sometimes go bilaterally in both optic nerves. And by deroofing of the optic nerve, you will be able to retrieve early that tumor out and decompress the optic nerve before even you start the manipulation of the nerve to take the rest of the tumor. So this is very important step I'd like to do. And of course, be aware of the perforators. These are a few examples I have done with the technique that we flatten the orbit and we just do the Terion approach with the resection of the lateral solid ring, release some CSF from the basal system, and then nicely you can take this tumor without any effect, as you see, as this brain was not touched. Pre and post-op, same like this one. We thought this is the pericallose artery might be encased, but actually there was a CSF around it that at the end we could release it and it went without any problem. This is the picture I'd like, I call it the functional exposure. That what you need is not 5 centimeter exposure in the width, 1.5 centimeter. That's why you need to elevate that frontal lobe, and usually with the gravity will do. And then you will see this is the tumor here. And at the end of procedure, pituitary stalk, right optic nerve, and here you see the chiasm and post optic nerve. This is actually done with the mini approach. I will show one video, an interesting case, 37 years old with headache and left visual loss. It's a small tumor, but I elected to go from the right side because the line of vision was important for me. It's a medial to the optic nerve, and I thought I will do best without touching the dominant hemisphere. This is, I have different technique, but this is one of the technique. I like to use it, start with the needle to puncture the cistern, and then I use the scissor. And now we are seeing that the optic nerve still covered with some arachnoid. I kept the arachnoid around it. This is the right optic nerve. And you see there is a tumor tongue there going even on the right side, a small one, but this is the eye that is intact. And this is a small cotonoid with surgical. I learned this, I call it the soft tissue retractor. This is from Professor Yezaji. More than 30 years ago, I learned this one. So it elevates the area without putting retractor there. And now I devascularize the tumor from the tuberculum celli. And of course, Doppler is an essential tool whenever you do these cases, very important. And I rarely use the CUSA in these cases because while you are doing from the contralateral side here, you don't know if the CUSA will be a little bit deep and might puncture the wall of the carotid and you will be in trouble. This is the contralateral side. We pass the midline and drilling the optic canal roof from the other side. We have learned with hyperostosis in the skull base to take bilateral optic roof by drilling from one side. And this technique, it's very easy to do, is not far away. And you see I am in the canal, take that tumor tongue away. I cut the falciform ligament. Now I continue with mobilizing the nerve. I put the Doppler to identify the location of the carotid under the optic. Once I identify this, I can feel now, after disconnecting the tumor from the tuberculum celli, I will be able to go around and start peeling the arachnoid. This is the most important. Arachnoid should not be coagulated and welded to the tumor, because then you will pull vessels and optic nerve on it. So you just peel. This technique, the forceps technique, this is Majid Sami's technique. It's very helpful. And once you detach the tumor from the skull base, it makes you able to mobilize this nerve right and left away. See now, since it was taken from its attachment, partial resection, but this tumor is, what's left is not very big, and it will be taken since it was disconnected. Keep arachnoid down, and it peels very nicely and it comes out. Now, I'll just show you, this is the carotid artery and the left optic nerve, as it's not, see the perforators coming from the vessel, very nicely maintained. And we'll give you an endoscopic view. We'll put the endoscope to see if there is any residual. You see how nice the view will be. Give you the carotid, perforators, optic nerve on this left side, which was compressed, posterior clinoid, and this is the third nerve covered with the arachnoid. If I move more, you can even see the stalk displaced. This is the stalk on this side, what displays going to the diaphragma. And we saw the small nipple of tumor left, so we took it and finished it. But tumor like this is a different story. This tumor, you see the vessel, the carotid and its bifurcation, everything is inside the tumor. This is a case where I have to do a partial resection. Now, I'm not a fan of revascularization. Perhaps I don't have the know-how very much. I am not have done a lot of these cases because the results were disappointing. How much vascularization to the perforator, this is very important. And sometimes you want to achieve this to the small perforators. And this case underwent a partial resection. But the case after, this is an anterior clinoid. Let me show you the images. A big tumor, anterior clinoid. This case, I have not done the drilling of the anterior clinoid, but you will see what we have done. Terional approach, flatten the orbit. Standard, I put usually a piece of gloves, or the best instrument not to adhere on the brain, better than any patty, but I put the patty on top of it. And I start again the arachnoid. We go further. I just want to show you how the tumor first was very adherent to everywhere, but eventually, here, I don't like to use the CUSA. We don't know the exact location. The tumor, the vessel is partially at the base, almost at the center of the tumor. So partial decompression after devascularization, under vision, and use different direction, different approach from medial or lateral. And Doppler kit is your very helpful tool to identify the vessel. This one, my resident edit this video just recently. So it could have been trimmed more, but again, the arachnoid membrane dissection, this is what I call it. Microsurgery is the essential part. If you have a much wider exposure and you don't do this, you will be in trouble. I had to go to the end of this video so I don't lose time with this. Now I took the outer part and from the Doppler I could identify the carotid and the bifurcation. This is the medial part. And again, here we achieve a good resection with excellent visual outcome on this patient. So prevention of vascular complications, important to review the vascular integrity preoperatively. Doppler, as I said, avoid too much coagulation and manipulation, like a traction on these vessels, generous irrigation, and prepare for a potential vascular graft if you need from the superficial temporal artery, but as I mentioned, I'm not very convinced with the results, and be aware of the deeper vessel. The outcome of surgery has many factors, but the most important is the surgical experience and how much you will go with the aggressiveness of the resection. We always try to take the tumor completely out. The visual outcome is influenced by the severity and length of the and history of the visual loss preoperative. Patient with complete blindness for 2 years is not going to get better. They should have some light perception and the recent changes over a few weeks or months. Surgical techniques is very important, and early post-operative visual recovery, it tells you that the outcome will be even better. Simpson grading, is it applicable to the skull base? To some extent, yeah. But I remember a nice paper from Roberto Hero, perhaps Jack will be happy to see that paper. He insists that not only Simpson grading, but MIP1 is very important, even in grade 1, to evaluate the potential recurrence even with the complete resection. This is a very important paper we should, and that's why we send all the meningioma to check that MIP1. We applied the same concept with a simple approach and with the help of endoscopy, even for other areas like the Mickel scale. I used the suprameatal approach retromastoid to the apex of the petrous. You see here how this, I was actually, this is exactly what you need. And these are cases, in the past I always thought I might consider the sigmoid approach, but this one, if you look to this venous system, the sigmoid lateral sinus is very prominent. It gives no space to Troutman triangle to go pre-sigmoid. So good that I didn't do that, and I decided to go, as I mentioned, and we put at the end the endoscope inside the tentorium from below and retrieve that small tumor. This is OR intraoperative in the brain suite. We did the follow-up, which was nice resection of it. It's another case, a small meningioma at the almost causing trigeminal neuralgia, resected in the same technique with a minor approach. So this is the view. When you put the endoscope, you find a nice view to this ambient cisterna, and when you incise the tentorium, you can retrieve a smaller tumor from there. Same with the pituitary. Now, 99% pituitary approach should be a transfemoral. We leave some for the giant to go from above, and this is the approach. And I think for meningioma, 2 indications might be a potential. One of them is the subdiaphragmatic meningioma as classified by Pamir and Al-Mufti, because this is purely intracellular. So it will be very feasible to take him from transfemoral approach, and there are colleagues they have done. I am still a fan to go for a meningioma from above. one case of meningioma, clivus meningioma. It was not my intention. They thought this is a chordoma. We went transnasal, and it was a meningioma that we resected nicely without consequences. So midline clivus meningioma might be the future potential to go on this way. This is post-operative. Bifrontal approach, I said, I don't like it. It gives you a large flap. You have to deal with the supraorbital nerve bilaterally, frontal sinus, dural sinuses, two frontal lobes, bridging veins, and as I mentioned earlier, the hidden neurovascular structure to the end of the procedure, and it has long corridor. At the end, I like to use this, I give this measure. Human being is born with affinity to novelty, innovation, and to overcome challenges and complexity. When we were young resident in training, somebody tell me, take this convexity meningioma. I say, no, I don't want this meningioma. I want to have CP angle meningioma. We like the challenge. This is human nature, the more difficult situation. But then when I read that book, the wabi-sabi concept is a Japanese style of living, emphasize simplicity, and that's what I showed in my presentation, and appreciate imperfection as a step toward perfection and integrity. You have to keep the patient. Integrity is very important. You don't want to take a tumor for the patient from the tumor from the patient. You don't want to leave a 45-year-old lady with a severe facial palsy and swallow problem if that tumor is attached, sorry, to the nerves and the brainstem, and you cannot dissect it. So you have to accept sometimes an incompleteness, and there are alternative options for management. Thank you very much for the time.
Thank you. Thank you, Professor Ahmed, for this nice talk and nice overview of these approaches of middle line of skull base. And really, we appreciate your message to young neurosurgeon and your wisdom about this topic, skull-based neurosurgery. So I think the third speaker will be introduced by Professor Ammo. Professor Ammo. Professor Ammo.
Professor Ammo, please unmute yourself.
Yes, that's right.
Yeah.
Hello.
Okay.
We are trying to. Professor Ammo, we don't hear you. Okay.
Okay. Is it right?
It's right.
Okay.
Yeah, right. So my thanks, all my thanks to Professor Najal Abadi and the organizers giving me the honor to introduce Professor Abdeslam Al-Khamlichi. Abdeslam Al-Khamlichi is a brother of mine, so it's not easy to speak about him without emotion. Abdeslam Al-Khamlichi, Mr. Abdeslam Al-Khamlichi is professor of and head of Department of Neurosurgery, Vice President of and Honorary President of WFNS. His efforts have earned international grateful recognition to the Moroccan Society of Neurosurgery, organizing the famous World Congress of WFNS Marrakesh 2005. Professor Abdeslam Al-Khamlichi has entered neurosurgical publications. I remember especially those treating about healthcare and medical formation in Morocco, and those treating about the state of neurosurgery in African countries, and has also research works studying the circle of Willis development during fetal, infant, and adult age, introducing a large study of intracranial aneurysms in Morocco. I remember also a nice research study on so-called benign increased intracranial pressure. This work started early 80s, I think is still on progress somewhere at the Cambridge University of Harvard. Professor Absam Al-Khamdishi is known worldwide, sharing knowledge with colleagues and neurosurgical societies in both Americas, Asia, Europa, Middle East countries, and all over Africa. He is founder, president, and or past president of a lot of local, regional, continental, international neurosurgical societies. Professor Absam Al-Khamdishi is the founder and president of Hassan II Foundation of the Prevention and Cure of Nervous System Disease, as well as the director of the WFNS Rabat Reference Center for Training of African Neurosurgeons. Thanks to these two active structures that are the first chain link in the field of formation of African neurosurgeons, there are several dozen, several tens, maybe 100 neurosurgeons spreading out all over the sub-Saharan countries. So it's difficult to summarize Professor Al-Khamdishi curricula in a few minutes. And to conclude, as the president of the MNCL, I must say that we are pleased that Mr. Al-Khamdishi, retired from official public duties, gives us the honor to join the Association of Liberal Practice Neurosurgeons in Morocco. We wish to him the start of new active life, and dear brother, welcome in your family. And that's it.
Thank you, Sabla.
Welcome. Welcome.
Professor Khamdishi, you can go ahead. Okay.
Professor Khamdishi, please unmute yourself.
Hello.
Hello.
Do you hear me now?
Yes, yes.
Yeah, okay, sorry. So I said thank you, my dear Abdullah, for your kind words. And thank you, Najia, for your invitation to participate in this webinar. I'm, of course, very happy, and it's my great pleasure to share this webinar as speaker with my two close friends, Jack and Imad, two really distinguished and outstanding neurosurgeons. It's, I think, also an occasion for me to thank and congratulate my Moroccan colleagues, leaders of Moroccan neurosurgery, for all their effort, combined effort, to make progress in this continual medical education program. So I will share with you my experience on the management of large and giant pituitary adenomas. Yeah. So first of all, just some general features on pituitary adenomas in general, whatever is their size. Of course, they're known as a benign tumor and typically slow growing. They're quite frequent, represent between 10 and 15% of intracranial tumors. The goals of management, of course, is the maintenance of the pituitary, the normal pituitary function after removal of the tumor, the normalization of hormone secretion in endocrine active tumors, and of course, avoiding and trying to minimize the adverse effect of the treatment. In the last 2 decades, there have been a lot of advances in the management of pituitary adenoma, and I would like just to mention 2 of these advances. First, the new WHO 2017 classification of pituitary adenomas, which I think contributed to many things. First, to change some terminology, replacing pituitary adenomas with the pituitary neurotumors, variability of invasiveness and malignancy, and replacing also the term non-functional pituitary adenoma with null cell adenomas and silent pituitary adenomas, and replacing also the replacing also the atypical pituitary adenomas by aggressive or higher risk pituitary adenomas. But I think the main contribution of these advances was the clarification of the complex process of adenohypophyseal cells differentiation and hormone production of pituitary adenoma based on the adenohypophyseal cell lineage, and which is determined by the pituitary transcription factors. This is really a new and very important knowledge in the pathogenesis of pituitary adenomas, which will have certainly in the future a lot of positive consequences on the management of these tumors. Now, what we mean by large and giant pituitary adenoma, there is no consensus on the size of this tumor, but in general, we consider that the pituitary adenoma are large when they have a diameter of more than 3 centimeters, or they're giant when they have a diameter of more than 5 centimeters. However, if we consider the different morphological classifications of pituitary adenomas already existing, maybe we can have better definition of this group of tumors. And the first one of this classification, which goes back to more than 40 years, with done by one of the pioneers of the pituitary surgery, Jules Hardy, and it was based on sphenoid bone invasion and destruction. And you see the 5 stages or grades he described. The second one also from the same author, based on the size of the tumor, microadenoma, less than 10 millimeter, macroadenomas, which can be intracellular, which can extend in supracellular region, symmetrically and having different grades, grade A, B, and C, and then asymmetrical, which means lateral extension with grade A and grade D. And the last morphological classification was based on the invasion of the cavernous sinus, which was described by Knopf. If we try to mix all these classifications, we can say, you see here, the Hardy, the Knopf classification and the 2 Hardy classifications, and we can say that the grade 3, 4, and the grade C, D, and E are really corresponding to the group of large and giant pituitary adenomas. And I would like just to show you some pictures of this. Here is, of course, the picture of normal hypophysis, microadenoma, and the intracellular macroadenoma, the grade A supracellular extension, the grade B supracellular extension, grade C supracellular, which is already a giant one, and then the lateral extension and the extension in all directions, really representing these huge ones. Maybe our colleagues working in Europe and North America are not seeing them, but we have still a lot of these tumors in our places, and we have to deal with these patients. Are large and giant pituitary adenoma more aggressive or more high risk? Of course, we can answer no if we take in consideration only the size of the tumor, but the large and giant size of this tumor increases the risk, of course, by the compression before surgery, by increasing the compression, by the need of multiple surgical approaches to remove these tumors, and also by the need of multi-modality treatment in addition to the surgery to try to cure or stabilize this tumor. However, if we consider our daily practice and how we deal with this large and giant tumor, well, our answer could be yes, because these tumors are more likely to be associated with the thick and firm structure of the tumor, which of course make a challenge its removal through the transsphenoidal approach. It can be associated with invasiveness of the surrounding neurostructure, neurovascular structure, which makes in many cases, when it's large and giant, its removal almost impossible. And of course, it can be associated with the tumor markers and tumor of a tumor aggressiveness, which are shown on the immunohistochemistry and molecular biology, and of course, which, as we will see later, show us that these are really higher risk tumors, which almost cannot be cured in most of the cases. So what are the modalities of treatment for these large and giant pituitary adenomas? Of course, as they're large, they are already compressing the surrounding structure. And surgery is, of course, the first technique to be applied to treat this tumor. And the transsphenoidal approach remain the most frequently used, but it's not always sufficient, as we will see in this kind of tumors. This transsphenoidal approach has moved into many innovations in the last decade. I am practicing this approach since more than 40 years. I started in 1979, and I started with sublabial transseptal approach, which I changed in 2003 to the transnasal using extramucosal transnasal approach. And of course, in the last decade, many young colleagues are now using endoscopic approach, either associated with microsurgery or as a complete technique to remove the tumor. Here is a case I would like to show you, quite large one, in a lady, 44 years, non-functional pituitary adenoma, which was approached by a transsphenoidal approach. You see here the position of the patients, the X-ray tracking, and we use the endonasal, as I said, the introduction of the speculum in the endonasal, using the turbinate as the main landmark, with the inferior one, which is exactly in regard of the lateral part of the septum, and then after this repair, the coagulation of the septum, the subluxation of the septum to the left side, and you see this nice typical view of the lower part of the sphenoid sinus. And when you have chance, you can see the both osteum here. And this is the reason why I keep this video to show it many times. So you open the osteum exactly as our colleague doing by the endoscopy they do. You open the sphenoid sinus, you coagulate the mucosa, and then you see the floor of the stellar turcica. And you see how the compression made the bone very thin. After the X-ray tracking, you open the stellar turcica, and then the coagulate the dura, you open it, and you see that by chance the tumor is very soft and the tumor will come out very easily using different sizes of the curettes. You can completely remove this tumor, and then you close the floor of the silla with small bone, some Surgi cells, some fat, and of course some glue. And then you reduce this small luxation of the septum, and you pack the nose. You see the post-operative control, of course, with the packing you have here, and to close the sella. This is the second one, quite large also, but soft. We succeed to remove through transsphenoidal approach. Third one, again, removed by transsphenoidal approach. But in this case, a young man, 20-year-old, non-functional pituitary adenoma. The adenoma is well presented, bulging in the sphenoid sinus with a large sphenoid sinus. So you can be very optimistic before surgery to remove it. But look, after the transsphenoidal approach, we succeeded just to make biopsy and a very limited removal, because the tumor was firm and we couldn't remove it. And we, of course, made the frontolateral right approach to remove this tumor. And you see here, of course, the respect. We dissect the arachnoid plan, as it was already said, and the protection of the right optic nerve and the opening of this capsula. You will see that it's very thick and not easy to remove through transsphenoidal approach. And even with the curate, very small tissue is coming out, but the tumor is bleeding. And of course, we try to dissect the capsula from the left optic nerve and then resect it completely from the surrounding sella turcica dura. And after this side, it will be dissected, of course, from the right side here. And then, as you see now, from here is the right optic nerve and the resection of the tumor. Of course, in such cases, the pituitary stalk cannot be seen because it's completely invaded by the tumor. And then when the capsula is completely resected, by respect of the arachnoid plan and pushing this arachnoid plan to the chiasm and the floor of the third ventricle, we can completely remove this tumor, which of course it's quite, I think, difficult to be done through the transsphenoidal approach. And then you see the arachnoid plan respected, and this small part of the tumor, which is in the sella turcica, will be removed after coagulation with this curved bipolar. And then with the curate, we can remove completely this part of the tumor. And you see here the post-operative control. Here is another situation. This patient was operated in 1995. And in the operating notes, it was noted that he had a gross total resection. But we didn't have any post-operative MRI, and the patients disappear after after he leaves the hospital. And this is, unfortunately, is quite frequent situation in our places. He will come back 9 years later with this huge tumor, as you see here. And we tried again the transsphenoidal approach. We succeeded just to make biopsy and very limited resection. So we go through the craniotomy, and you see how this tumor is thick, but it's not invasive. This is the most important difference in this large tumors. When they are not invasive, you can remove them. You see that you can dissect it from the brain parenchyma, and of course, cutting piece by piece and remove it, dissect it from the carotid artery, who is, as you see, pushed high, and then from the anterior cerebral artery and remove, of course, completely this tumor. As you see here in the post-operative control, and the patients you see here 16 years after surgery. This type of tumor, the most difficult, you see this shape of the tumor, dumbbell shape of the tumor, invading all area of the cavernous sinus. And you see here in CT scan, you think that it's anterior skull base meningioma. And at surgery, of course, using craniotomy, you see that the tissue is soft in this area, in the cortical area, but it's invading the cortical parenchyma. And of course, slowly we can dissect all this part, which is in the skull base part. But when we go to the sella turcica, look this invasion of carotid artery, of anterior cerebral artery, the perforators, the chiasm, the left optic nerve, the right optic nerve, and the hypothalamus, and the tumor. We try, of course, to debulk the tumor here between the optic nerve. Just what we can do in such cases is just a partial removal, of course, to decompress the optic chiasm and the optic nerve. Of course, by chance, in this large and giant and invasive tumors, we have other modality of treatment, mainly the medical treatment for secretin pituitary adenomas. Sorry for the slide, but there are a lot, of course, of drugs. Most of them are known nowadays, used in different secretin tumors, and others who under trial in clinical trials, which are maybe will be added in the future to this this medical treatment. And the third modality is radiation, mainly radiosurgery, gamma knife radiosurgery, which become widely accepted as the best complementary treatment after microsurgery in pituitary adenomas, with an increase in use in some specific cases as primary treatment. In our center, since we had our gamma knife unit in 2008, you see that pituitary adenoma come as 5 group of tumor we are treating, all of them, of course, after surgery. And we have just 3 or 4 years after starting this treatment, published our experience in this European journal, Acta Neurosurgica. And you see that the cover image, which was used in this issue, came from our paper, which was published in this issue in 2013. And I would like just to show you one example. Here, a case of patients operated in 2009 with a small remnant tumor, but which wasn't, which was controlled. It wasn't immediately treated. And in 2012, 3 years later, we have seen some increase in the volume, and then we decided to treat it with a gamma knife radiosurgery. And you see here on March 2020 the complete disappearance of the tumor, and of course the patient is cured with replacement therapy, hormonal therapy. This is the last case I am showing you. Very important. Patients 38 years with this giant GH pituitary adenoma with huge acromegalic syndrome, all metabolic disturbances. And of course, here is the control after surgery. Unfortunately, I don't have the picture before surgery, but believe me, the tumor was at least 4 times more than this. And when we had this large remnant tumor, we decided to treat with radiosurgery and with, of course, medical therapy. And look here, the evolution of this tumor 1 year later, a really large shrinkage of the tumor. And look here, 6 years later, the complete disappearance of the tumor, and the patients, of course, has stopped now the medical treatment, only the replacement treatment. Unfortunately, sometimes some of the tumors are, as I said, aggressive and high risk, and all these multimodality treatment cannot succeed to treat them. And there have been an interesting paper from a famous French neuropathologist, Troyas, who compared these pituitary aggressive tumors to the pituitary carcinoma, and he considered that they are almost the same. He has given an interesting title to this paper: Aggressive Pituitary Tumors and Carcinoma, Two Sides of the Same Coin. And he compared the characteristics of these of two series, one series on the left side of aggressive pituitary tumors and pituitary carcinoma. And you see, regarding the gender, regarding the type of the tumor, regarding the proliferative index, regarding the mitotic index, regarding some protein like P53, and the mortality. These are really the same, and the reason why he said that they are two sides of same coin. And of course, in this group of the tumor, today, the only therapy is some oncologic drugs like temozolomide and some other treatment. In conclusion, just an advocacy, of course, for early diagnosis of the pituitary adenoma, to have them when they are microadenoma, and to be able to remove them, to enucleate them by transphenyloidal approach, and to save the complete gland and to cure really the patients. But we had not to forget that a large number of microadenoma are discovered today with the MRI, so as incidentalomas without any symptomatology, and they don't need any surgery. We have to just survey and to see the evolution. If they become symptomatic or increase in the size, then we can go to surgery. The second conclusion is that the majority, of course, of pituitary adenoma are benign, slow growing, and more than 80 to 85% of this tumor, we can cure them and stabilize them. The third a conclusion is that the WHO 2016 classification of pituitary adenoma brings many clarifications on the diagnosis, treatment, and the prognosis of these pituitary adenoma. And last, a multidisciplinary approach to these tumors is a key for both clinical management of patients, for research, and of course, for future development. And I thank you.
Thank you so much, Professor Khamlichi, for this excellent and outstanding talk as usual. And thank you for your, also again, for your great job that you have done to introduce multimodality as radiosurgery in Morocco. And as you said, is the only way to deal with these huge tumors. So we can start the discussion, and I will ask the panelists, Professor Lakhdar, Professor Helmani, and Professor Ammo, to start the discussion about maybe the three talk or talk by talk, if they have to choose what they decide. Thank you.
Thank you, Professor Abadi. Thank you, Professor Jacques Morcos, for your very interesting talk about the orbital tumors. Yes, the orbital tumors is a field of is a part of the field of skull base surgery. I think in many country and the neurosurgical practice, the skull base surgeons are involved in orbital surgery. I think it's very interesting region and very challenging region because of the anatomy and the various histological type of lesions that can be located in the orbit. Also with many possibilities of approach. The most known and most used first was the fronto-orbital approach of Maroon and Kennedal that is well described in a paper in neurosurgery in the 18th, I think. And now we are in the era of endoscopic surgery. It's became easier and easier. I mean, it's becoming simple because of the technique and the time that it takes and the effort that it takes. It simplifies this approach in a very important way. So we have learned that endoscopic approach not in many difficult locations, like the apex, the orbital apex. It's a very complex region, but now we have seen with Professor Marcus that it makes the endoscopic approach makes it easier, and also with endocranial approach and communicating the orbital with the endocranial content. So thank you again, Professor Morcos, and if there is any question about the topic from the audience, please.
May have a question, but before, we have with us many people from around the world, from Russia, from Brazil, from Africa, Nigeria, and others country. And our friend from Algeria, Souad Barti, she would like to ask something. Fad, can you please give her?
Yeah.
Thank you.
Fad, please.
Hello, everybody. First of all, congratulations to all the speakers for the 3 outstanding talks, wonderful talks, really. We have learned a lot. And I want to share something with my friend Jack about orbital lesions. And I always say orbital lesion, as you say, we have many things in the orbit, malformations, tumors, and I must say that I don't have maybe your experience, but I'm dealing a little bit with these tumors. Until now, we have 140 cases. I use mainly transcranial and lateral approach. And in the field of pathology, one of my nightmare is first the hydatid cyst and also lymphangioma. Hydatid cyst, in our series, we have 5 cases. We have broken all the 5. It's not as in the brain. It is always adherent to muscles. And in all the cases, we have broken them. It seems that in literature, it is the same. And for lymphangioma, really, we try to operate them only where when you have a big proptosis or a decrease in visual acuity. But unfortunately, as you know, we operate and they recur. And so what is the solution currently? I know that many things have been tried, but what is the solution currently outside the sclerotic agent and maybe the cryoprobe of Matula? I don't know. Really, what is your feeling in this field?
Lymphangioma, or you don't mean cavernous angioma? You mean
No. Angioma, I'm very happy when I operate on cavernous angioma. I'm very happy. I'm talking about lymphangioma, Jack.
Yeah, I will disappoint you. We don't have a good solution. I work very closely with the oculoplastic surgeon, David C, TSE. He actually travels to the Middle East a lot. He gets invited to talk. And the cases I've done with him, and we have a bunch of recurrent ones. No good solution. Again, we tried to avoid operating because you almost always add insult to injury. They're enmeshed with the nerves. So I don't have any wise answer for you. One lesson I learned again, that's a neurosurgical myth of you always, people think you always have to reconstruct the orbital roof when you do orbital surgery. Not true. I used to do it on every meningioma, let's say, entering the orbit, and then I would reconstruct the mesh, and they would still have the same proptosis that they started with, even though I removed the tumor. But not reconstructing the roof has been very good I'm just saying this, it's unrelated to your question, but just reminded me something that we neurosurgeons probably do frequently. And I like to say that don't be afraid of not reconstructing the roof. That orbit, proptotic orbit, goes back in cosmetically, you'll achieve the result you want.
In this field, Jack, when I make my bone flap, monoblock bone flap, I try to keep the maximum of roof, and so I replace it because
sorry, go ahead.
Was it?
No, I agree with you. It depends what you started with. When you have these phenoorbital meningiomas with the eye so proptotic, and you remove it, and what I'm saying is, if let's say the roof was still intact, don't put that entire roof back in, because there seems to be irreversible changes in the soft tissue in the orbit that will not go back even though you remove the meningioma completely. And that's the only message I want to say.
Okay. So there is no solution for lymphangioma till now.
I don't, what I know, very honestly, I will, nothing new. I will contact, we have Bascom Palmer Eye Institute, world famous here with us, University of Miami. I haven't seen anything. I will ask David C to send you and me any updates he has. He's very interested in the non-surgical aspects of it too.
Thank you.
Just a short comment about hydatid cyst in orbital localization. It's you can try also the medical treatment. It's like, of course, spine localization. It's called white cancer, because we cannot, of course, resect it totally and without breaking it. So, of course, we are more. We have more recurrences, and I know that it's also a huge problem to solve.
Yes.
My question, maybe I can ask my question, please, Professor to Jacques. It's about a lateral approach, the Crowline, modified Crowline approach. I have a little bit experience, about 10 patients with our team of ophthalmologists who is specialized in orbit tumor. And when we did this patient with him, he of course cut all the muscles, and then when we remove the tumor, usually it's hemangiocavernomas, and then he sutured them. And the evolution after the functional evolution of the orbit is little bit. I'm disappointed a little bit about the evolution with this approach. What do you think?
Yeah, no, you mean he cuts the intraocular? I mean the.
Yeah, intra. Yeah.
No.
Completely, completely reverse the globe.
Oh, I see. No, we don't do it that way. I mean, we bring the microscope in and work with, you know, between the muscle groups. For a cavernous angioma, never any need to cut.
On orbital, only
Orbital,
orbital localization without inviting cavernous sinus.
Yeah. No, never any need to cut any muscle for. I mean, that's why you have the choice between all these sectors. And
when the tumor is deeply localized in the orbit.
Never had. We've never. When I say it's just not me. With me and oculoplastic, never had to cut a muscle to remove any lesion in the orbit. What I tell you, what they lack in, it's amazing. We neurosurgeons use the microscope every day. Even the best oculoplastic surgeons, they love to work with loops. It's been a struggle to get them, when I work with them, to actually use the microscope. I don't know how is your oculoplastic surgeon? Do they?
We use, of course, the microscope after, when he just reversed a little bit to have more space, a little bit corridor to have when there is a really deep localization.
Yeah, no, never had to cut muscles.
Okay, thank you.
I have one comment. Perhaps I haven't done hydrated cyst for a long time on the brain. Nobody mentioned about hydrogen peroxide to minimize the tension or the rupture possibility on hydrated cyst. And we used to do this around the cyst with the hydrogen peroxide patties that improve the tension and reduce the amount of the pressure within the cyst and rupture tendency. Anybody using this? Still using it? I don't know. This is a technique I have done years ago.
Yes, of course, in the brain always, but in the orbital localization is different, because you know the space is very close, very small, and the hydatid cyst, there is the multiple hydatid cyst, not only one big
single one.
Brain. In the brain, you use, of course, hypertension, and you can just we said accouchement. It's in English. Accouchement. It's the
delivery.
Delivery.
Technique of our friend from Brazil, Professor Amo. I learned with you my first case of hydatid cyst in 1987. It's a long time ago.
The delivery technique was described by Arana Inges.
Arana Inges, yes.
It helps a lot. It helps a lot in a brain hydatid cyst, of course, but in the orbit is the only location when it's I think authorized for all neurosurgeons to puncture the cyst and take out the capsula, of course, and to follow with the medical treatment. As today there is antiparasitic drugs which are very efficient with the treatment of 3 months. May I just I have question and comment for Jacques. My dear Jacques, thank you very much for your presentation. These topic and details about orbital surgery, I think all of us neurosurgeons are in need to know about this frontier surgery. Of course, all what you have shown is absolutely clear and important in these pathologies you treated, although the approach of small lesions located interiorly in the cavernous sinus, just at the bifurcation of the fifth nerve, like schwannoma, like meningioma, which can be treated nowadays by radiosurgery. Do you think that, of course, on your hand and on hands of those who are really on habit with such surgery, it's okay, but do you think that you can advise today neurosurgeons to make such common approaches to such lesions?
Abed, thanks for your comments. as you know more than I do, schwannomas very different animals than meningioma. So schwannoma of the cavernous sinus or superorbital fissure. By the way, I do gamma knife as well myself. The problem, of course, the proximity of the optic nerve that cannot get more than 10 gray of radiation. So if it is a schwannoma and if it is indicated to operate due to clinical symptoms, whether it's in the cavernous sinus or the orbit, if it's a schwannoma or a cavernoma, I will always favor surgery. Meningioma, totally different story. Again, I'm not Sam Al-Mafti, and I'm certainly nowhere as aggressive as he might be with meningioma of the cavernous sinus. But schwannomas are so easy. The capsule, even in the cavernous sinus, is so good, and the side effects of radiosurgery with the proximity to the optic nerve is significant. For those two reasons, yeah, I do recommend surgery for these lesions.
I have a question, please.
Yes.
Yes, Michael, first I want to thank our experts for their this amazing and inspiring talks. My question is for Professor Kanaan. You talk about using Doppler intraoperatively. Do you have how do you use it? And there's some tricks and some advices for your neurosurgeons.
I think the most important part, you should have studied your images very well, anticipate where the vessels and the branches are in relation to that lesion. When you put the probe, you know where it's putting and where you are suspecting the vessels to be. There is no trick, because this is the one we have is a bayonet. It's not the best in size, but it's still, I saw the one Jacques was using is a finer one. And I'm jealous about it, but you hear the sound and you can evaluate the proximity. Of course, the stronger than the major vessel, you will hear it very well. Especially when you are doing as well pituitary surgery and you want to know about the carotid and the cavernous sinus on both sides, if there is a tumor extension. But there is no trick. You hear the sound. It's not, I'm not watching the flow or the wave. I just be guided by the sound. So I make it very simple.
Imad, I have no financial relationship, but Mizuho sell, well, it's, I think, they sell a disposable one, so.
Disposable, yeah.
Work, yeah.
Bye-bye.
Thank you.
Do you use the same one? It goes for endoscopic as well, isn't it?
Yes. Well, yeah, the one I showed was not endoscopic.
Yeah.
But yeah, Mizuho has a nice long endonasal one.
Okay, thank you.
Thank you so much.
Thank you. Maybe Professor Ammo, Professor Himani, there is some question from the panelists before moving to all the participants. No? Oui, yes, Professor Ammo.
Oh, I would like to express my thanks to. Do you hear me?
Yes, yes.
Yeah, I'd like to express my thanks to the participants and to thank Mr. Hamlishi and all the orators about for their talks. Lovely talks. I have no more question. That's the first sequence of Moroccan webinars for 2020. And I hope, and I wish that we will have some interesting series before next month, inshallah. That's it.
Thank you, Professor Amou. We have with us Professor El-Azhari, and I know that he is very fan of this surgery for this region, and I wish you can give some comment. Please.
Thank you, Najia, and thanks all the the conference, the speakers, Professor Khamlishi, Professor Jacques, my friend. How are you? And
How are you? I
Imad
haven't seen you in a
also.
while.
And
Nice.
Imad, Professor Khamlishi also. Thank you very much. You know that's the sentence you make at the end, Imad, is the challenge. The human is born to challenge. So skull-based surgery is a big challenge, and I think it's challenge, but it needs some wise decisions sometimes. So thank you for your presentation, all the speakers. It was really very interesting, and I really enjoy after after many months we don't see you, but our hearts are so close. And thank you very much. Thank you, Najia, and thank you, Professor Khamlishi, Professor Jacques Morcos, Imad, Professor Hilmani, Professor Lakhdar, and Professor Ouammou. Thank you very much to organize this webinar. I think we will continue with the series of webinar. It's but I hope it's Corona go out, because I don't know. I don't want to have a season 1, season 2 of webinar, season 3.
Thank you.
Thank you. And I would say hello to Suad and to all my friends and brothers from Algeria and from Africa.
Thank you so much, Abd Samad, and really it was for us a great pleasure and a great moment to have all these speakers and amazing talk from Jack, inspiring with I love very much your case about EVM with collaboration with your radiologist endovascular to treat EVM by selecting the vein from the orbital to. It's really very interesting. And Imad, of course, you give us really a very nice, beautiful talk with many message, take-home message for young neurosurgeon, for more than young nurse, for the oldest of us, as the trip and the tricks in the skull-based meningiomas, especially in meningiomas, but to others, of course, tumors. And finally, Professor Khamlishi, dealing with this huge tumor is a big challenge. And unfortunately, we continue in Morocco to see these huge tumors. And hopefully for this type of tumors, pituitary adenoma, the multimodality, and as I already said, having the radiosurgery, gamma knife, and others now type of radiosurgery is one of the key of the treatment of these tumors. Thank you so much for everyone to be with us lately. Thank you, Jack. Thank you. Professor Ahmed, Professor Khamlishi, and I hope to see you next week on Tuesday. We will have our next vascular webinar with Professor Robert Spetzler, with Professor Sam Martin from Republic Czech, and of course with our friend Abd Samad Azhar. Thank you.
Thank you. Bye-bye. Take care.
Thank you very much. Good evening.
It
Have a nice weekend. See you.
Hope to see you soon. Take care.
Virtual. Hope that we can see each other.
Yeah.
Gently
Have
in
a
the
nice
coming
weekend.
month, inshallah.
Inshallah.
Soon,
Take care.
Take care. Stay safe.
Bye-bye.
Bye.
Bye.
Thank you, Fed. Oh, Kherdin, you are here.
Welcome.
Dear Kherdin, I'm so sorry. Je suis désolée, j'ai pas vu, j'ai pas regardé.
How are you doing?
On aurait voulu que tu participes, que tu nous donnes ton point de vue sur l'endoscopie.